You can say this at the end. You don't know. You don't know if you don't want to say it to me. It's really an honor to be here. I've come to understand over the last 20 years just how special this community is. Children, young adults, families, and yes, the providers and folks who support the providers. So I'm really honored to be here. I hope I can add something to the conversation. Because in addition to all the things that you all have to keep your eye on as you try to preserve freedom and preserve quality of life, you have things that push back and try to restrict freedom, quality of life. And that's urinary tract infection. It's one of those things. As if all of the rest weren't enough, there are these microorganisms. So I want to talk to you a little bit about not so much what is a UTI, but more how do we think about it in the clinic. It can be a bit nuanced. Just want to say that I got to Children's Seattle in 2000, and I was a physician, consultant in infectious diseases. That's how I trained. And then I operated a lab for about 10 years, dissecting bacteria like E. coli. I'm going to talk a lot about E. coli because it's the primary nemesis. Not the only one, but it's the primary nemesis. And we know some things about it, but it was in about 2006 that my life changed, my professional life, because Dr. Mitchell referred a patient to me. And she was, at that time, I think, a young adult already with recurrent urinary tract infections that were multi-drug resistant. I hope this doesn't yet sound familiar to any of you, but I acknowledge that it may. And so that sort of began a journey where I've worked with, in succession, Dr. Grady, and now with Dr. McGarrian in trying to preserve freedom for you, for your children. Disclosure, I consult for and have equity in a company that produces a device that processes poop to fill capsules for use in poop transplant. I'm not going to talk about that, but we can talk about it later or off to the side. I think I'm kidding. All right. Am I doing this? Who's doing this? Yes. So I'm comforted to know that a lot of great education material on what is urinary tract infection is already available to you. This is the handout from the ABC website produced by Dr. Ranjit Matthews. You know. I don't want to add to that. I can't do better than it. It just points out a lot of things that we'll talk about. But I know this is out there. I want to get into some of the more challenging aspects of it. Okay, but in short, urinary tract infection, of course, is when a microorganism, a bacteria typically, it's usually from our own bodies, from the intestinal tract, enter the bladder through the exit, entering through the exit into the bladder and possibly up the ureters into the kidneys. So, two very closely related questions. How is urinary tract infection diagnosed? How do you make the diagnosis? That's all fine. Of course, we do want to make a diagnosis. And it's important to have criteria. But the fact is, in patients who are at risk, who we know are at risk of having a UTI by virtue of this variation on anatomy, Sometimes we make a diagnosis, sometimes we treat as though we have made a diagnosis. So these questions are subtly different. When should a patient be treated for urinary tract infection? When the patient has painful urination, difficulty catheterizing, if they are catheterizing for continence, that can be due to bladder spasms, flank pain, fever, vomiting. It's pretty easy to say, yeah, I think we've got a urinary tract infection when these things happen. It's easy to make the diagnosis. It's when we have situations that are short of that, for you, for your children, that we kind of do a lot of hand wringing, right? So what if the urine is dark, it's cloudy, or it's foul smelling? Well, you may of course hear from your urologist, from your team, to increase the fluids, increase the frequency of catheterization. Let's see if we can just knock this out before we pull the trigger on antibiotics. And here I'm going to pause and say, my other job at Children's Hospital is in the position of antibiotic steward. It's not really as fun as being a wine steward, right? Although some days as an antibiotic steward, you wish you were a wine steward or had access to one. The job of the antibiotic steward is to think about how all the providers at our hospital are using antibiotics and trying to avoid overusing. There are certain populations where overusing antibiotics, and that can mean using them when you shouldn't use them, using ones that are too big when you should be using ones that are more narrow, or using longer when you should be using a little bit shorter. Being a steward means protecting a precious resource. So in that regard, we do want to have some rigor, some care around when we call a set of symptoms a UTI and when we treat with antibiotics. Because using a lot of antibiotics out of proportion to the urinary tract infections can add to the restrictions on freedom. We want to push back and preserve freedom. So that means protecting your children from antibiotics if they're not needed. And it can actually mean protecting your children from providers that are well-intentioned and want to do something to help your child. And that can lead to unnecessary antibiotics. So as an infectious disease doctor, it is my job to over-prescribe, but that's how I was trained. That's what we do. The world is a nail, and I've got the hammer, and so that's what I do. And that's what a lot of providers do. And providers are well-intentioned in doing this. We need to work together to find those right criteria to say we're doing the right thing. So if the urinalysis that's taken shows a significant number of white blood cells, there may be a urinary tract infection. For example, some of the numbers we throw around, if there are greater than 10 white blood cells per high-powered field on the microscope, odds are it's a urinary tract infection. If it's greater than 20, it's definitely a urinary tract infection, right? And antibiotics should probably be spared. The urine culture of a true UTI should show one organism, not two, not three, or more. And it should be an organism that we know is capable of causing irritation and inflammation of the bladder. And not every microorganism is equally capable of doing that. Some organisms are virulent. That's our scientific word for nastiness. E. coli is virulent. It is the most virulent when it comes to the bladder or the urinary tract. It has the capacity to make people with traditional urinary tracts sick, let alone what it does for variations in the anatomy of the urinary tract. That's how we know E. coli is virulent. It can cause UTI in just about anybody. Pseudomonas is also in the category of more virulent. But interpreting these, there are many caveats. There's a lot of hand waving, and I'd like to say it takes a lot of data, a lot of hand waving. Is this the right thing? A lot of hand wringing. And the reason that I hand wring when I'm taking care of a patient with bladder exstrophy, hand wring around a urine culture is I want to make sure that if I'm giving antibiotics, it's going to do more to preserve freedom than to restrict it. And preserving freedom means keeping our antibiotics effective for you guys, for us all together, to keep our toolkit, to keep our medicine cabinet full of effective antibiotics. So in summary, as I've been saying, not every positive culture is an infection. Not every positive culture needs to be treated. I think I'll have to leave it there. It's a conversation. A quick tale of two bacteria, okay? You see these two shapes. This is the shape of an E. coli. It's longer than it is wide. And these two bacteria are filled with, on the left, DNA, the genetic plan that carries all the information about how to do virulent things. On the right is a little gray circle. It's not the standard genetic material, it's bonus genetic material. Here are two different bacteria. 1970s E. coli, when we first started to understand which E. coli were nasty and virulent, which ones were just kind of there and didn't do too much. And on the right is 2000s E. coli, the modern E. coli. On the left, the DNA, that standard DNA and the bonus DNA has these orange asterisks. Each one of those is a virulence factor. It's a specific gene that not all E. coli have. It could be a gene that tells the bacteria how to make a slimy capsule to protect it from antibodies, or it may be a toxin that poisons our white blood cells. Virulence factors. So 1970s E. coli was virulent. It was nasty, but it was antibiotic susceptible. You could treat it with almost anything. Well, guess what? Guess what we have now? We've got the same virulence in our E. coli, but we've got resistance to C, ciprofloxacin, the most powerful of the oral antibiotics. We have resistance to 3, the third generation cephalosporins, a very powerful IV antibiotic. We have resistance to G, gentamicin, an aminoglycoside. We have resistance to B, Bacterium, another powerful, important oral antibiotic. Notice there are two different things going on here. There's virulence and there's resistance. They're not the same. Let's take a step back from tale of two bacteria to, is it algebra or geometry? This is geometry. So this is a geometric space. We have two axes, X and Y. In this case, it's to show that virulence and resistance are different. We get them confused as providers, but they're different. I'm going to show you E. coli. It's way up high on the virulence axis, the y-axis, and it goes all the way from hardly resistant to totally resistant. They're independent properties. And now we have E. coli that can do it all. They can be virulent, cause disease, even in healthy people, even in people with typical urinary tract anatomy, and they can be highly resistant. We've got Pseudomonas aeruginosa. It's not quite as virulent. It takes variation in urinary tract anatomy for a Pseudomonas to make someone sick with UTI, but they are pretty resistant. And we move down. Enterococcus, another bacteria that lives in the intestines, less virulent, can be resistant. And then there's Candida yeast. Candida yeast has a really hard time causing urinary tract infection. It is not virulent. It needs there to be a tube sitting in the bladder for it to cause trouble. Okay, so virulence and resistance are separate. And these are the kinds of things that I, as a provider, need to take into account when I'm looking at a culture to say, do I believe that this is causing the symptoms that my patient is presenting with? I feel like I'm just going to keep blathering on and on. So I'm going to need some kind of indication of where we are time-wise at some point. What, 5 minutes? Five minutes, right? So in patients that have recurrent urinary tract infections, the bladder, if the bladder is all native bladder tissue, that portion of the bladder gets very irritated. And it actually, in protecting itself, can shed its outer layer. So the ability of the bladder lining itself to protect against urinary tract infection is itself damaged by urinary tract infection. So that means one infection is more likely to be followed by another one, unless we can stop it. So sometimes in bladder exstrophy patients, we want to just pave the road. We want to make for a smoother ride. We're going to pave it with an antibiotic that protects against some of the more virulent bacteria like E. coli. And the best antibiotic for doing that is coming up. Here it comes. It's nitrofurantoin. Nitrofurantoin is the greatest antibiotic. There are other options, but they're not the greatest antibiotic. I'm going to keep going. In spite of our best efforts, sometimes things break through the road paving, and these are breakthrough infections. Yes. Why is nitrofurantoin the greatest antibiotic? It doesn't overpromise. It does what it's supposed to do. It treats bladder infection because the body gets rid of it in the pee. On its way out of the body, it's doing the thing that it's supposed to do. And it doesn't go out through the intestine where all the good bacteria are. Good bacteria of the microbiome preserve freedom by protecting and suppressing other nasty bacteria like E. coli. We don't want to mess with the good bacteria. That's where the food transport stuff comes in. I can't talk about that. The medication is generally very well tolerated. It's very narrow in spectrum. It's effective against the susceptible E. coli and the vast majority, like 98% of most even very, very resistant E. coli. What an amazing drug. Its capsule form is generally cheap, and the powder has virtually no taste and mixes well in food when patients are small. Next slide. Antibiotics, other than nitrofurantoin, damage the gut microbiota. We need those good bacteria in the intestine. They are protective. They are part of the immune system. We think it's only us in here. It's not. It's half us, half our good bacteria, right? Half the cells in the body are microbes. Got multi-drug resistance, nitrofurantoin still works. Look at this nasty bacteria. Look at this test result. A lot of nastiness, a lot of resistance, but nitrofurantoin has green arrows that I put on there to show you. Next, please. So the treatment of breakthrough urinary tract infections is like this game. What's this game called? Yeah. And so I'm sure many of you are familiar with this game. And even folks who do a lot of this end up with that feeling like, oh. So what can we do about it? Breakthrough infection. Again, it's treating only those episodes where there are white blood cells in the urinalysis, not some of the other symptoms that can mimic or even anticipate UTI. We need to see those white blood cells. We want to avoid using our big tools like the oral ciprofloxacin, that very powerful antibiotic, when other options exist. Some patients, this is, I may just skip on over this. Yeah. And some patients need longer treatment dose. If you have a cluster of infections and we're just not getting on top of it with the prophylaxis, we may need to do a longer treatment, and we need to talk to you guys, the urologist, the infectious disease specialist, about what's going on. Does something else need to be done? Because that bacteria is hard to eradicate. Let's see, this could maybe be the last thing. The individualized antibiotic plan. This is something that we're piloting at our clinic. We think about the infection before the infection happens, so that when the infection happens and the clock is ticking and symptoms are getting worse and you all are getting more worried and your child is getting more miserable, we have a tool in place in the electronic health record that may speed things along for decision making. We're still figuring out how to do this. This is a work in progress. But the document is something that should be there with a click in your child's medical record, available for any provider who can access your child's medical record in the system where the plan is. That's a challenge. But basically the plan provides for 3 scenarios. One is the prophylaxis scenario. What antibiotic are we using, if any, to pave the road, to prevent infections? Because sometimes we use antibiotics to save antibiotics. So for dysuria, painful urination, and white blood cells in the urine, in this case, we may continue nitrofurantoin. It only sounds like a bladder infection, so let's go from once a day to 4 times a day. And keep that narrow, just right Goldilocks, not too big, small, hot, cold, antibiotic. Let's go with that. If that doesn't work and we progress to fever and flank pain, maybe we need to do something stronger like an IV. And depending on your child's microbiology and pattern, we may want to start using more of a single dose of antibiotics, aminoglycosides. I said I wouldn't talk too much about it because of my 5 minutes and the whole thing. So how do we do this? Your child has a consultation visit with a specialist who can look at all the microbiology results that you guys have had and your antibiotic allergy history, if there is one. We create an individualized plan, and then we put the plan into the electronic health record with the caveats that I gave you about, well, who can access it. Okay? Beware of antibiotic allergy labels. If you have an antibiotic allergy history or label, think twice about it. Is it really an allergy, or is it simply a reaction? Because I'll tell you, in the vast majority of cases, most things people have experienced are reactions that are real. They're not allergies that could lead to something dangerous. And this is all in the spirit of preserving freedom, preserving that full medicine cabinet. Because we know when we get away from the drugs we love, we get into trouble. Here's my simple advice on gut health. Get this book, Food Rules, and read it. It's fun. It's not a terrible book. It's not a boring book. I read it when I was waiting for my annual physical with Dr. Khan a few years ago. And then I bought a copy, and we love it. It's got kind of wisdom that's fun. Like, what should I eat? Food rule 1, what should I eat? Eat food. The thing is, not everything that we eat is food. So this is where the whole thing about shop the peripheries of the supermarket, the produce, the meat, dairy, and stay out of the middle, the things with boxes that are made in the laboratory with lots of ingredients that we can't pronounce. Processed food is not good for our happy gut, and it will restrict freedom, not preserve freedom, like the good gut health advice from Food Rules. Next slide. Yeah, imagine butyrate. I'm going to leave it at that. I don't have time. We'll talk about it later. Imagine butyrate. Butyrate is the latest. It's the sexiest thing. It's what your intestinal epithelial cells eat. We eat food, but our cells eat butyrate. You know what makes the butyrate? Our good bacteria. So if we're feeding good food to our good bacteria, they're going to make butyrate and feed the intestinal epithelial cells. It's all good. So if you're doing, if you eat that avocado and that wheat and the spinach, you're getting soluble fiber in your diet, it's all good. That's called prebiotic. Prebiotic. Feed the bacteria, and they'll take care of you. Next. You ready? Summary. Pave the road, right? We talked about that. Nitrofurantoin, best antibiotic. Not every positive urine culture means infection. Not every antibiotic reaction is an antibiotic allergy. Push back on these allergy labels. Plan for Goldilocks antibiotics. Not too big, not too small, just right for your child, for your microbiology. And for optimal gut health, follow the food rules. Imagine butyrate. Read about butyrate. You know, they say a lot of great things about that. And I believe them all. Thanks so much.